Let's begin. Bismillahirrahmanirrahim. My topic is endocrine hypertension. Vakas, you have fantastically set the tone for this webinar, and you have left a little time for me. I'm grateful for that. So endocrine hypertension is a very vast topic. I have to cover it up in 20 minutes, and I'll try to do that. So let's move on with case number one. I would like all of you to respond in the chat, and let's see who amongst you comes up with a quick answer, right? So let me just put my chat box open. That's it. 28-year-old Mr. Salman presents in clinic with high blood pressure readings at home, more than 150/90 consistently. His father had hypertension. He complains of severe lethargy, weight gain, as well as erectile dysfunction. On examination, his blood pressure is 155/93. Some of you still reaching to the diagnosis. You can just type in and think what it could be, right? Okay, he has diffuse goiter and he has delayed relaxation of deep tendon reflexes. So you've got the answer ready with you, or why the hypertension is there? Yeah, is the chat open? Any one of you? Okay, so don't see any responses yet. I move forward. Lab workup shows TSH of 98.5 and a free T4 of 0.36. So this is the case that we see pretty often, hypothyroidism, primary hypothyroidism. And you see simple case of hypothyroidism presenting as hypertension. And many a times we miss these simple cases of primary hypothyroidism who present as hypertension. So why are we worried about hypertension at all? So look at this. Now, established hypertension will affect kidneys, the heart, the brain, leading to chronic kidney disease, myocardial infarction, heart failure, ventricular fibrillation, stroke, and all of these leading to death. So morbidity and mortality just goes up. And that is why we are worried about hypertension and, more importantly, endocrine hypertension today. So when we talk about hypertension, we have got primary hypertension, which is 85 to 90% of hypertension, and secondary hypertension, which the numbers and percentages constantly increasing as we have more modalities to diagnose things now. Secondary hypertension being 10 to 15% at the moment. So if we see in less than 40-year-old, we see that 30% of hypertension is secondary hypertension in people who are less than 40-year-old. And this number is actually squeezing because of the more obesity and insulin resistance that's coming in the recent decades. We are seeing more of essential hypertension actually coming in. In children, 50% of hypertension is secondary hypertension. So as the age is going low, our focus on secondary hypertension becomes even more intense. So when we talk about secondary hypertension, we are talking about cardiovascular causes or endocrine hypertension or renal hypertension. Now, today I'll be talking about endocrine hypertension, and thankfully I'll not fully remain focused on adrenals. I'll try and swing here and there as well. So this is the slide, endocrine hypertension, and this is the crux of my presentation. It's a very busy slide. I'll move forward and decipher this slide further. So let's move on to case number 2. Be with me on the chat so that we can communicate, right? So case number 2, 18-year-old Mrs. Seher presents with chronic diarrhea, palpitations, and weight loss. And let's see who diagnoses the case pretty early, as I say. On examination, her blood pressure is 160/95 millimeters of mercury. She has hand tremors, diffuse goiter, proptosis. And you all have already diagnosed that this is a case of hyperthyroidism, right? TSH is suppressed, FT4 is high, TRAb is positive. And you all know that now the diagnosis is refined to Graves' disease. So a simple case of hyperthyroidism coming in the clinic with palpitations, diarrhea, weight loss, hypertension, and again, the simple case of Graves' disease. So when we think about hypertension and when we think about endocrine hypertension, yes, a lot of it is focused on adrenal glands, but we need to be in check whether it's another gland abnormality. So coming up to causes of endocrine hypertension and adrenal dependent causes, we have got 3 major diseases like primary aldosteronism, which is common now and becoming more and more common. pheochromocytomas and paragangliomas, and Cushing's syndrome. And Waqas has very beautifully presented adrenal Cushing's just before me. There are more causes that are linked with the genetic causes as well. Hyperdeoxycorticosteronism axis, the congenital adrenal hyperplasia, not the common variety, but the uncommon ones like 11 beta hydroxylase deficiency, 5% of CAH, and 17 alpha hydroxylase deficiency, and also the deoxycorticosterone producing tumors. Then we have apparent mineralocorticoid excess, the 11 beta hydroxysteroid dehydrogenase deficiency, which may be genetic and acquired, can be because of the licorice that comes with the herbal tea. So other causes, so we have seen adrenals to a little bit, we have seen thyroid, parathyroid dependent causes. So even hyperparathyroidism can present with hypertension. And then the pituitary-dependent causes, where we have acromegaly, growth hormone excess, even growth hormone deficiency can lead to hypertension, Cushing's disease, thyroid-dependent causes. We've already discussed a couple of cases like hypo and hyperthyroidism. And then secondary hyperaldosteronism, where we have the renovascular hypertension. Other causes include obstructive sleep apnea, where you have daytime somnolence and increased blood pressure, obesity, which is rising and causing more of hypertension because of obesity, insulin resistance, metabolic syndrome, and again, testosterone deficiency in males can also lead to hypertension. Vitamin D deficiency has also been linked to in many studies and systemic analysis as being very closely related with hypertension. So when we talk about hypertension, we know that much of it is primary, essential, and some of it is secondary. But of course, in many patients, and especially with the rising obesity and insulin resistance and metabolic syndrome, there is more of essential hypertension that is coming up in the younger age as well. So it's important to identify the clues where we need to go on and find a reason whether there is any secondary hypertension or not. So hypertension in less than 30-year-old without positive family history, hypertension and hypokalemia, severe hypertension, more than 160 systolic and more than 100 diastolic blood pressure, resistant hypertension, which is uncontrolled or poorly controlled hypertension on at least 3 antihypertensive drugs, malignant or accelerated hypertension with end organ damage, fluctuating hypertension, hypertension in adrenal incidentalloma, positive family history of endocrine disorder like men, pheochromocytoma, and thyroid disease. So these are some of the clues that bring you closer to diagnosing a secondary reason for endocrine hypertension. So again, symptoms are very important. So starting from the clinics and history, and then your examination, and then comes your lab investigations, you try and pick up clues whether there is anything that give you clues towards secondary hypertension. So again, headaches, sweating, palpitation, flushing, weight loss, weight gain, all these symptoms should raise our ears about considering secondary and especially endocrine hypertension. On examination, abdominal striae, a thyroid bruit, lab investigations, potassium disorders like hypokalemia, hypercalcemia, hypo and hyperthyroidism, and hypercortisolism after suppression testing. And in radiology, of course, we see adrenal masses. We had a lecture on adrenal incidentalloma last time by Dr. Asghar. And again, asymmetric renal size, whether there is any polycystic kidney disease. So this is the very system that is causing hypertension in patients who have endocrine hypertension related to adrenal glands. So this is the angiotensinogen, which gets converted into angiotensin 1 through activation of renin, through renin stimulation. Angiotensin 1 through ACE gets converted into angiotensin 2, which promotes the release of aldosterone, and both aldosterone and angiotensin 2 then helps in tubular normal saline, sodium chloride reabsorption and potassium excretion, also water retention and volume expansion. So this is the whole physiology that works beautifully errors in this system can lead to endocrine or adrenal hypertension. So let's move on to case number 3. So now we already discussed hypothyroidism, hyperthyroidism. We said parathyroid hyperparathyroidism can be a reason for hypertension. And we talked about a little bit about obesity and metabolic syndrome and obstructive sleep apnea. Moving on to case number 3. This is a very typical case that we see in our clinics day in and day out. So be with me, and I'll need your support in moving on forward with this case. A 56-year-old man presents in your clinic with 20-year history of hypertension. 20 years history of hypertension, poorly controlled on 5 medications. He's on lisinopril, 20 milligram daily, spironolactone, 50 milligram daily, hydrochlorothiazide, 25 milligram daily, metoprolol, 100 milligram daily, amlodipine, 10 milligram daily. And despite these 5 medications, his blood pressure is still 165, 110. Now we see in our clinics patients coming up with 2, 3, 4 antihypertensive medications and still blood pressure hovering around in ranges more than what are ideal. So can anybody just think aloud loud in the chat box? I mean, what condition you would think of in this particular case? He's 56, of course. He was diagnosed with hypertension at the age 20 years down the road when he was 36, right? And now he's 56. He's in the age bracket where we suspect more of essential hypertension. He's on 5 medications and still uncontrolled. What is the condition that you would think of when you're sitting as and thinking, can it be a secondary hypertension? Can it be endocrine hypertension? Renovascular hypertension, okay, good. Anything else? Renovascular hypertension, atherosclerosis, okay. Anything related to adrenals that you can think of that tends to get missed? Again, renovascular, yes, Suresh. Anything else? Hyperaldosteronism, Simon Zabe, good. Again, FEO, yes. So FEO comes, FEO will come in episodic hypertension initially, and then you can have a sustained hypertension as well. But hyperaldosteronism is something that tends to get lost, and recent studies show that there is more and more percentage of hyperaldosteronism in our patients who have resistant hypertension. Absolutely, Suresh. Hyperaldosteronism has to be ruled out in a person who has resistant hypertension, more than 3 medications, still uncontrolled. When he was diagnosed, he was 36, but of course, he was not picked up at that point in time. So moving forward, clues to primary aldosteronism again. So hypertension and hypokalemia. But remember, hypokalemia is sometimes when we talk, we think hypokalemia is going to be there in all patients. Now, it may not be there in all patients. It's usually seen in around 30% patients. The rest may not have hypokalemia, especially this person was already on spironolactone. Again, resistant hypertension, severe hypertension, more than 160, 100. Adrenal incidentaloма and hypertension should be worked up for aldosteronism. Onset of hypertension at a young age. Now, recently we talk about less than 30. Less than 40 is always not a bad idea. Family history of early onset hypertension or CVA at a younger age. All first-degree relatives of patients with primary aldosteronism. And remember, primary aldosteronism, it's not only about hypertension only. Remember, the ultimate goal of picking up hypertension and treating hypertension is to reduce that morbidity and that mortality, cardiovascular mortality that is associated with it. And we know primary hyperaldosteronism has significantly higher rate of cardiovascular events. And that is the reason I'm more interested to focus on primary aldosteronism and picking it up early in these patients. So hypertension and hypokalemia, which can be seen and is usually seen with primary aldosteronism, this is a topic in itself. So if you have hypertension and hypokalemia, you start checking aldosterone and renin. Now we know that renin is basically producing, or it's stimulating aldosterone to come up. So when aldosterone is high, the renin should go low physiologically. So again, in aldosteronism, primary aldosteronism, the aldosterone concentration is high, the renin is low. So aldosterone is high and renin is low. So this is automatic aldosterone production that's coming in primary aldosteronism. Now, there can be conditions where both renin is also high and aldosterone is also high. And these conditions include renovascular hypertension, renin secreting tumors, malignant phase hypertension, the renovascular disease, coarctation of aorta, and also diuretic use. And then there is a situation where the primary aldosterone concentration and the renin activity both are low. And these are the conditions where a lot of genetic defects are present, like congenital adrenal hyperplasia, TOC-producing tumors, and 11 beta hydroxysteroid deficiency, Little syndrome, and in all these, there's hypertension and hypokalemia with low aldosterone and low renin. So again, which medications? Now, the important thing is this person is on many medications and you think that this can be primary hyperaldosteronism. You want to go and test it. So which medication should be stopped before screening primary aldosteronism in this patient? Be with me. Come back in the chat box. Lisinopril, spironolactone, hydrochlorothiazide, metoprolol, amlodipine, all of the above. Which medication you want to stop? Yes. Spironolactone, definitely you need to stop that. You need to not block the mineralocorticoid receptor. What else? Spironolactone, what else? What about the lisinopril? What about amlodipine? So it's a tricky situation now. Now let's see the next slide. Now, these are the medications that have an impact on aldosterone and renin and on the aldosterone-renin ratio. Now, if you see, most of these medications are having an impact on aldosterone-renin ratio. All A, B, C, D, the ACE inhibitors and ARB and the beta blocker and the calcium channel blocker, the dihydropyridine ones, and the diuretic, all four A, B, C, D affect the aldosterone-renin ratio. And spironolactone, of course, blocks the mineralocorticoid receptor, so you have to stop that as well. So you are left with limited choices when you are checking aldosterone-renin ratio. You only have verapamil, which is again a calcium channel blocker, non-dihydropyridine. And then you have alpha blockers like prazosin and moxonidine and hydralazine. So you have these medications to replace with. Now, this patient who is on 5 medications, already uncontrolled, you can't stop all of these and start maybe 2 or 3 of these and consider safe. Of course, that blood pressure can go skyrocketing high. Patient can land up with a stroke or a heart attack. So ideally, what should we be doing? So this is a tricky situation, and that's the reason many physicians would try and avoid, just try and add another agent actually, rather than going on and working up with this patient from primary aldosteronism. So replace the existing regimen with a combination of a calcium channel blocker and an alpha blocker, and potentially with moxonidine or hydralazine. That's not possible in most patients, if not all. So if withdrawal of other medications is not feasible, then only stop diuretic and the mineralocorticoid receptor antagonist, leaving the patient on a regimen that includes beta blocker and calcium channel blocker, and ACE, ARB, and alpha blocker. And if you can stop the ACE and ARB, that's going to be great. So again, continuation of mineralocorticoid receptor antagonist is acceptable in patients with severe hypokalemia, because if you stop spironolactone, the potassium actually can start dropping, which can happen. And again, when you're checking aldosterone and renin, you need a normal potassium to actually get the best result with the ARR. If interfering medications are continued, then interpreted renin and aldosterone measurements in the context of known effects of these drugs on the ARR. So you should know what these medications have an impact on the ARR, and you have this here. You see beta blocker will increase the ARR. You see other medications impact like ACE inhibitor and ARB will reduce the ARR, and so does the calcium channel blocker. So you have the impact known to you, and according to that impact, you can then try and stopping these medications. So again, the other technical problem with somebody who is coming to your clinic with routine hypertension, talking to you about the hypertension, and you say you may have a primary hyperaldosteronism, and the patient says, I'm having the hypertension for the last 20 years, and now you want to investigate it. But the investigation is not just one test. It has to be a screening test, and then a confirmatory test, and then an imaging, and then you may need an adrenal vein sampling as well. And in most endocrine diseases, you have biochemical evidence first, and then you have the radiological evidence. And again, in many of these endocrinological disorders, you have the screening test and confirmatory test, and then the radiological investigation, and then you may need another testing as well, like adrenal vein sampling in this patient. So you do an aldosterone-renin ratio. Renin activity can be done in most part of this part of the world, we check the renin concentration. You see the ARR ratio. If that ratio is high, you go on into a confirmatory testing, which is a salt loading test. I'll tell you about that. But if the ARR, aldosterone renin ratio is high, and the patient has resistant hypertension, potassium is low, renin is undetectable with a high aldosterone of more than 20, then you do not need a confirmatory testing, right? You can straight away proceed for imaging. But in most patients where potassium is not high, renin is detectable to a certain extent, aldosterone is in the gray zone, not too high, between 10 and 20, you should be going on and doing a confirmatory testing. Then after confirmatory testing, an adrenal CT scan, and then if needed, an AVS. After the adrenal CT scan has been done and you have the result with you, you either have a unilateral region or you have bilateral hyperplasia or nodularity sort of region. And according to that result, you then plan whether you need an AVS or not. And I'm not going to go into the detail. Remember, surgery has two folds, right? I mean, the treatment is twofold. Either you treat with spironolactone, the dose of which you can definitely increase, but side effects will also come in, or you have the surgical removal of the adrenal gland, of course, unilateral in most cases. So screening tests, so aldosterone concentration and renin activity or renin concentration, you take a ratio of aldosterone and renin. Of course, in primary hyperaldosteronism, aldosterone is high, and because aldosterone is automatically high, the renin gets suppressed, goes low, and in most cases it is undetectable, so the ratio of aldosterone to renin is usually high. And the limits are different. For example, the aldosterone concentration to renin activity ratio cutoff is more than 20, but aldosterone concentration to renin concentration ratio more than 2.7 is what we take as a cutoff. So again, when you have the initial screening test as positive, and you see that your patient has an undetectable renin, high aldosterone more than 20, low potassium, resistant hypertension, you straight away move towards imaging. Otherwise, go to the confirmatory testing. Now, I'm not going to the detail of confirmatory testing. You can go on and read. This is oral salt suppression test where you give oral salt, and it's an IV salt loading test where you give IV salt. The concept is what you should clear. When you're giving salt to the patient, the aldosterone should go low, because when you're giving salt, then the kidneys don't need to conserve that salt. So the renin will go low and the aldosterone will go low. But when there is a primary hyperaldosteronism and you give oral salt or IV salt, whatever the protocol is, which I'm not reading for the sake of time, your aldosterone, if it doesn't get suppressed to a certain number and it remains higher than a certain number, then this is confirmed that this patient has hyperaldosteronism. Then comes the imaging test. So it's very important that imaging comes after biochemical testing. So again, adrenal CT scan, very important. In adrenal CT scan, you'll either get a bilateral masses or a nodular micronodularity, which is bilateral, or you get a unilateral hypodense lesion, a nodule which has more than 1 centimeter marked PA. So again, if you have a unilateral lesion, one side, tumor is more than 1 centimeter, and you have got marked primary aldosteronism, you have low potassium already seen. You know this is highly to be primary hyperaldosteronism. Age is less than 35 years. You may straight away move towards a laparoscopic adrenalectomy, unilateral. But if the age is more than 35 years, you're not sure whether this lesion is an adrenal tumor or an adenoma producing aldosteronism, then you go towards an adrenal vein sampling. Likewise, if you have bilateral masses, again, you move towards AVS. But remember, patient's will is very important. Patient who doesn't want a surgery and he says, I don't want surgery, I don't care whether it's primary aldosteronism or not, and I just want to be continued with medical treatment, then of course you don't need to move into all these pathways and do all these things, and he can be managed again with pharmacological therapy. This is the adrenal vein sampling. As I see my time is also coming to a close. I'll move forward and not go into the detail, but it's basically right and left adrenal vein compared with periphery. Aldosterone is compared with cortisol, and then the ratios are checked. and a ratio of both sides. If it's more than 4, it's a unilateral disease. Less than 3, it's probably bilateral. So again, principles of treatment is very important. Remember, it's not only, say, in hypothyroidism, you could have given only hypertension could have been treated with an antihypertensive, but you needed to diagnose that hypothyroidism because there can be there are other things that are linked with hypothyroidism. So it's not only about blood pressure, it's controlling the other things that are associated with these diseases. Coming up to the next case, 27-year-old female presents in the emergency room with severe headache, palpitation, and sweating. She presented with similar symptoms twice in the last 1 month. She's recently married, let me tell you. Her blood pressure is 185, 115. Her blood pressure was also elevated last time she was seen in the ER, but it was attributed to anxiety and headache. No family history of hypertension. Will you consider secondary hypertension in this case? Okay, so they say pheochromocytoma. Okay, so again, pheochromocytoma is something that can get missed because patient gives you a history that I went to a certain GP, the blood pressure was high, comes back to you, the blood pressure is normal. You always remain in a fix whether the blood pressure has been high or not. But again, I think pheo has a very low percentage, probably because it doesn't get picked up. So pheo or paraganglioma, you have spell-related symptoms like anxiety and diaphoresis, dyspnea, epigastric and chest pain, headache, hypertension, nausea and vomiting, pallor, palpitation, and tremor. And chronic symptoms, once you have those catecholamines getting released again and again, you get this fatigue, generalized increased in sweating, hypertensive retinopathy, hyperglycemia, resistant hypertension, orthostatic hypotension, congestive cardiac failure, and you can get a global myopathy, cardiomyopathy as well, painless hematuria, and weight loss. So again, when you have pheo, there are a lot of medications that can actually hamper your measuring of metanephrines and normetanephrines in the blood and in the kidneys and in the urine. So again, tricyclic antidepressants, antipsychotics, bispirone, MAO inhibitors, cocaine, levodopa, labetalol, cetalol, the list goes on. And you can always check this list before you order the test. So you need to stop all these medications at least 2 to 4 weeks prior when you're checking. Again, there are foods that are known to increase catecholamines, right? Vanilla, banana, cocoa, dark chocolate, walnut, citrus fruits, tea, coffee, pineapple. A tea addict like me who takes 8 cups of tea every day and has to check his levels of catecholamines, has to stop taking tea for maybe a couple of hours before the test is done. So again, biochemical testing first, and then you go towards the radiological imaging. So when you see the test, it's metanephrines and normetanephrines that are tested. The plasma metanephrines have a higher sensitivity. For a positive case, it will detect, and most of the times, 99%. Specificity is more with the urine metanephrines, 98%. So usually in clinical practice, if you combine the urinary and the plasma metanephrines, you have a high sensitivity and specificity to detect these cases. Again, evaluation and treatment of catecholamine-producing tumors. You discontinue interfering medications. Clinical suspicion is high. You go towards urinary and plasma testing, the metanephrines and the normetanephrines. And if the suspicion is low, you take a more specific test like a urine 24-hour urine metanephrine testing. If the urine testing is more than 2 times the upper limit and the serum testing is 2 to 3 times the upper limit with a strong suspicion, there is no more confirmatory testing. Thank you very much. So you can directly go towards the imaging. Now, in this case, again, you do a CT scan of the adrenal glands or an MRI. The CT scan of the abdomen will tell you, focusing on the adrenal glands, whether you have an adrenal pheo. Remember, you still can have a paraganglioma, which may be extraadrenal. You've seen it in the bladder. You've seen in the headache neck region. So, well, again, so first doing a CT scan of the adrenal region, if you have negative imaging, then you can go for a PET scan or an iodine 123 tagged MIBG scan. And again, if you have an adrenal lesion and it's more than 10 centimeter, then you should also this patient get worked up for a metastatic disease and consider genetic testing in this particular patient. The important thing is when you're sending this patient for surgery, there has to be an alpha and beta blockade before the patient lands up into surgery. So you start alpha blockers 2 weeks prior to surgery, and then 3 to 4 days before surgery, you also start a beta blocker to actually block that alpha beta receptors so that the patient doesn't go into hypertensive crisis when he is in surgery. Moving forward, case number 5. So you see two 50-year-old women. Now, you've already done you've already taken a webinar last week. Dr. Abrar presented adrenal nodule. Bakas also touched upon this. So give me the right answer for this, right? So again, you see two 50-year-old women with adrenal incidentallomas. Axial CT images of their adrenal masses are shown. Which patient should be screened for FEO? Now, this is a patient who has a Hounds. I'm sorry for the bad quality of the picture. This patient has a adrenal nodule with a 1.2 Hounsfield unit. Will you screen this patient if this was an adrenal nodule? Will you screen this patient for FEO even if he has hypertension? Should this be screened with a 1.2 Hounsfield unit nodule there? Yes or no? Yes. Less than 10, benign, and less than 10, no FEO. Yes, no. So of course, you say no, fantastic. So you're not screening this for FEO, but somebody, another scan, similar patient, 35 Hounsfield unit, that's a FEO. That can be a FEO. That can be malignant as well, of course. Yes, fantastic. So good. So screen for FEO if the Hounsfield unit is high. Case number 6, so 29-year-old female presents in clinic, and I'm not going to go into details of this because I'll finish up with this case. Wakas has already done a good job. 29-year-old female presents in clinic with lethargy, body aches, and weight gain. On examination, she has proximal myopathy. Blood pressure is high. Potassium is low. What do you suspect? Yes, Cushing's. And Wakas, you've done a good job. I'll move forward, come up to the conclusion. Fantastic. So endocrine hypertension is common amongst cases of secondary hypertension. We should keep our threshold low for investigation. We should be open to history and examination points to actually just pick up these cases. Hugely undetected cases. The reason is maybe due to complex testing and diagnosis, screening tests, confirmatory tests, radiological tests, your AVS. So this can get difficult sometimes for patients because you call them again and again. So better thing is to counsel them initially that if we go into testing, this can be the time frame and this can be the testing that can take place. Minimal clues should be taken for framing suspicion. Screening test should be the first step. And with this, I think I should thank you all for patient listening and communicating well with me on chat.